My name is Stephanie Nix, and I'm a genetic counselor at Levine Cancer Institute. Hopefully you can all see the slides that I'm sharing now. So this is a presentation that I put together for you all that I want to give you a nice overview of genetic testing and cancer genetics so that you have a good basis to understand why some people may be referred for genetic testing and what those results might mean for you. So here's a few things that we're going to talk about. I would love to be able to get some questions. So either unmute yourself or put it in the written chat and I'll try to respond that way. And Leslie, you can help me. So the most important thing to think about with cancer genetics is we talk about genes. And I love to use the comparison of a gene as being like a recipe. And what these genes do is they encode a sequence that is the instructions for how our bodies function. And so we have genes that control how tall we're going to be and what our blood pressure and kidney function look like. We also have genes that their purpose is actually to protect us from developing cancer. So this is a normal part of our body. So we get one copy of every gene from our mother, one copy of every gene from our father. We have 46 chromosomes, and there are about 30,000 genes total in every single cell of our body. Now, let me click through the full animation. A mutation is simply a change in the DNA, and changes or mutations can occur at any time in any single cell of our body. What we're talking about with genetic testing is actually the inherited mutations. So this would be having a gene that has a mutation, a change in it that has been inherited from mother or father, and that gene is then present in every single cell of our body. And that's in comparison to a single cell having a mutation in it. That's different. All right, so what causes gene mistakes or mutations? The biggest thing is just chance. These things happen randomly. Every cell in our body replicates itself and makes a new cell, and that's how we're repopulating our body cells all the time. So a mutation can happen when there's a simple error in this process. So you can see here that dog starts out spelled correctly, and a mutation happens where the G gets replicated, and then all of a sudden I have more G's than I need to, and that can be enough to make us actually break the function of a gene. So apart from just random chance, the environment is another big factor that can affect whether mutations occur in cells. So we all hear about sun exposure. There's other things like tobacco smoking or chemicals in the workplace like asbestos that can increase the risk for mutations to happen. Lifestyle can play a role in this also. So we mentioned cigarette smoking, but wine consumption, nutrition, whether we have a healthy lifestyle, all of these things affect our body on a daily basis. The last thing, which is really my piece of this puzzle, is inherited mutations. So mutations can happen just in a single cell, and over time that can become a cancer cell. So I have an image on the next slide. Here we go. So an individual who does not carry a genetic mutation from birth, then look at the top line. So the two blue chromosomes here represent a normal copies of genes. Whenever some type of environmental factor occurs or randomness that results in a mutation occurring in a single cell, then you still have two copies of every chromosome and every gene here, but we've got one that has a mutation that means it's not working. The other copy is still working, so that may be enough to protect us from developing cancer. But as time goes on and other insults from the environment occur, we can end up with a second mutation, and that ultimately lead to what causes a tumor to grow. Now, if you look at the bottom image, the difference here is that this is a person who in every single cell of their body, they already have one of these cancer genes that does not work. It's broken from birth, basically. And so because of that, it doesn't take as much of the environment to induce a tumor to occur. So this is the example of the top line, what we think about random environmental cancers that occur during our lifetime, and the bottom is inherited mutations. So I have a little quiz here if someone wants to unmute themselves. Does anybody know what percentage of breast cancer is actually hereditary?
15%.
15%, exactly. I think a lot of us estimate that to be higher because, we all think about my mother, my grandmother had breast cancer. I worry about my daughters or my sister's children having cancer. And so we may think that risk is actually higher, but you're correct. What we have here is honestly that 5 to 10%, maybe up to 15, are hereditary. That means that everything else, 90, 95%, it happens because of an environmental or a non-hereditary reason. Now, the unique thing about this pie chart here is you'll see that the difference between sporadic and familial. So sporadic are those cancers that we think about being very, very environmental related. There's not any genes in specific that are involved in this. Familial occurrences of cancer basically mean that there are clusters of cancer in the same family. And we don't really know, is it because they share genes in common, or is it because they have a similar environment? Maybe they have the same lifestyle. Maybe they grew up in an area of the country that had water runoff of pesticides or something else environmentally that may have resulted in that. But overall, I just generally think about all cancers being 5 to 10% hereditary. When we do genetic counseling, we draw a picture of the family tree, and you can see here, this is what we call a 3-generation pedigree. So if I am the circle on the bottom with the arrow, then the person next to me, the square next to me, is my brother. And then the square and circle above me are my mother and father, and then on from there. So a 3-generation pedigree includes my generation, my parents, and my grandparents. We also would include our children in this. So if we had children, then we would include them as well. So it could be, we can draw a pedigree that may be 4 generations or more long. When we take a family history during genetic counseling, what we are doing is trying to get the big picture on the whole family, not just who has cancer, but everybody in the family. And then when we think about cancer risk, we want to document who has had cancer, what type of cancer they had, what age of diagnosis the cancer occurred. And we absolutely understand that we don't know everything about our relatives. We don't know often what type of cancer someone, could have had, and medical records honestly may not be related. Like just imagine that there may be information in the family shared that my grandmother had bone cancer. Well, that could be a primary bone cancer, or it could have been a breast cancer that became metastatic and went to the bone. And we won't know that based on that information. So we take what information we can and put it together. There are some red flags that we think about with family history and occurrence of breast cancer. So you all have probably heard this. The younger age of diagnosis, the more concerned we are that cancer is due to an inherited genetic variation. Some type of a genetic syndrome caused it. In breast cancer, I think mostly about age under 45. That's my biggest red flag, is under 45. It could also be that a woman has had more than one occurrence of breast cancer, perhaps bilateral breast cancer, individual tumors, not one tumor that's spread to another local region, but individual tumors. It could be that the family history shows that there are multiple people with the same type of cancer. So perhaps I've had bilateral breast cancer and my sister had a breast cancer also. We count that as 3 occurrences total, 2 for me, 1 for my sister. We could also look at the rareness of a particular type of tumor as a red flag. So you all have probably heard about ovarian cancer, and we know that that is more likely to be associated with some type of a genetic variation. Colon cancer, stomach cancer, uterine cancer, having lots of polyps. And there's two things that should be on this list that are not necessarily, and that could be having a close relative with pancreatic cancer or metastatic prostate cancer is now by themselves, those are red flags. So if I have breast cancer and I have one very close relative that has pancreatic cancer, I qualify for genetic testing. So we look at this whole picture, and that's why a good family history is important. We want to get that detail about the family history and confirm the pathology of the cancers that we're talking about. Now, some people come to see us in genetics because they know someone who's had genetic testing or they've heard about it from a friend. Others get referred because of their personal or family history by a physician. And generally speaking, if you or your family members have had cancer before the age of 50, you've had cancer more than once, you've had 2 or more family members with the same kind of cancer, or you've had a family member that says that they have had some type of abnormal genetic testing. So a cancer genetic test that showed a mutation. Specifically, cancers that are the bigger red flags for me would be ovarian, metastatic prostate, and pancreatic. If I hear those 3 things, then I would recommend a genetic counseling appointment. What happens in an appointment is talking. I had somebody today say that she came to a genetic counseling visit with a sister, and we said, well, what information do you remember about it? And she said, it was a lot of talking. And it is, we talk for sometimes 20 minutes, sometimes 30, 40, 50, whatever we need to get the information that we need. But our goal is to get the personal history, family history, talk about the genetics of cancer, talk about how frequently a cancer may be inherited versus not. We want to talk about what genetic testing is, what the benefits are, the limitations. We want to talk about the consequences of a test. What would happen if your test were positive? What would we do? What would we recommend? We want to make sure that the person who's considering genetic testing thinks through all of those options and that they are actually ready to make the choice to do that. There's 2 reasons why genetic testing is different than other types of testing. One reason is because having a genetic test that tells us that you are predisposed to cancer is somewhat predicting the future. It's never 100% on whether you will develop that cancer, but it at least is telling us that you have a much higher risk than we expected to have a cancer in the future. The second thing is because we share genes with our relatives, my positive test result is going to be information that will impact my close relatives, and they may need to be offered some testing too. We also make follow-up appointments with anyone that we need to, be that a breast surgeon or the genetic physician at the hospital at Levine. So it just depends. We make referrals as necessary. So here's what a family tree might look like. This is a touch exaggerated, but you get the picture. If someone did have a BRCA mutation, so again, I'm the person with the arrow pointed at me. I might be 45 years old, and you can see here that I have 3 sisters and a brother, 2 brothers. And one of my sisters had breast cancer at age 50. One of my sisters died of ovarian cancer at age 38. If you look at this picture, what I hopefully you can see that the pattern that comes out of this is cancer in every generation. What that's called is autosomal dominant. That means that if there is a genetic variation that a person carries, then their children and siblings each have a 50% chance to also have that genetic variation. And then the risk for cancer to occur depends on the particular gene. And we'll talk about this in relation to BRCA, because those are the ones we think about most often. An updated pedigree for this may also show a brother with prostate cancer or a relative with pancreatic cancer or even melanoma. BRCA2 can have melanoma associated with it as well. Everybody's heard about BRCA1 and BRCA2. You look on the internet, you read a newspaper article, or I guess people don't read newspapers, read magazines, and you'll see that people know about the BRCA genes. These, are the longest discovered genes that we have that tell us about our breast cancer risk. So BRCA1 and BRCA2 are called tumor suppressor genes. Their job is really to make sure that the DNA stays stable and that any damages that occur in DNA get repaired so that it doesn't eventually become a tumor. Got some fancy words here: incomplete penetrance. That basically just means that you can have a BRCA mutation and never get cancer. Okay, it's not 100%. The risks are quite elevated though compared to average. So in the table on the left, you can see cancer type breast. The general population, assuming that there's no mutation, has about a 12% likelihood to develop breast cancer in the lifetime. If we have a BRCA1 mutation, that risk goes up to about 80%. BRCA2, we still say about 80%, it may be slightly less. Ovarian cancer, also pretty significantly increased risk, 20 to 40%. Male breast cancer, a lot of men don't think about the fact that they can get breast cancer. If we have a man that has breast cancer, even if he has no family history of breast cancer, we're going to offer genetic testing to him because it's rare. And again, that goes back to one of our big tenets of red flags. Is it very rare? Yes. In this case, we need to offer testing to him. BRCA number 2 is more highly associated with male breast cancer. Prostate cancer is very common in the general population, but again, we can see prostate cancer that's more aggressive also occurring in BRCA1 or 2 carriers. And then pancreatic cancer. Pancreatic cancer is thankfully not very common even in BRCA mutation carriers, but it is a difficult cancer, difficult to treat, diagnosed late. Often we don't have great screening for it. So if we know that someone carries a BRCA mutation, it gives us the opportunity to set up a screening program for all of these cancers. All right, there's way more than BRCA though. We have 84 genes that we often do testing for at one time. Only 9 of those are really considered high risk genes. So this information shows sort of the difference in the risk level. BRCA1, BRCA2, and the others in that top category, they're the most elevated risk. We have good guidelines. We've studied them well. They're more straightforward. If we get one of that type of results, come back with a mutation. The moderate risk genes definitely increase the risk for breast cancer above the general population. And there's usually guidelines, but they're still newer on the information. Medical management may honestly be based on family history and test results, not just on the test results like what a BRCA gene result would be. And then we have a list of newer genes that there may not even be any specific management guidelines available. We may not have any recommendations for family member testing, but testing is still offered to family members to see if they carry the same variation. But we really go back to the family history to guide us. One thing that I like to stress is even when genetic testing is done and the results are normal, it doesn't take away the fact that there's cancer in the family. We still want our relatives to get a checkup. We still want our female relatives to get a mammogram, even if I have genetic testing. Normal genetic testing doesn't rule out that there's some risk for other people. It's very reassuring, but I still want relatives to have breast screening. The rule of thumb is 10 years prior to the youngest age of diagnosis in the family is the age that relatives should start screening. Here's another image that talks about breast cancer risks. You can see in the pink bar graph that BRCA1 and BRCA2 have the highest risk, apart from the TP53. The condition that's associated with is called Levine, and that one can have very, very young onset of breast cancer, and then other more rare cancers like sarcomas too. On the left, you can see a pie chart that shows you of all the hereditary breast cancers, what portion contribution to each of these major genes have. And you can see that BRCA1 and BRCA2 are still the highest overall. They're nearly 50% for just those two genes. The other genes on the bottom, you can see PALB2, CHEK2, ATM, BARD1. Those account for about another 25%. And then the other genes are smaller. And one thing I didn't say before, where BRCA1 and BRCA2 have breast and ovarian and prostate and pancreatic and maybe melanoma risks associated with them, some of these other genes may just be breast, or they could be breast and pancreatic, or breast and colon. So it really depends on the specific gene, what cancer profile might be at risk with that gene. All right, so how do we decide who gets to have genetic testing? I mentioned before that we take that 3-generation pedigree, we look at pathology results, we review medical records from oncologists, and we look at our national guidelines to tell us who we should offer genetic testing to. This set of guidelines first looks at age and says if we're under age 45, then we qualify to have genetic testing. Next, if there's 3 total breast cancer diagnoses in the family, that qualifies. Also, I mentioned before about the close relative with pancreatic, ovarian, metastatic. Also, Ashkenazi Jewish ancestry is another criteria that would qualify a woman with breast cancer to have testing. Metastatic breast cancer is also another newer information for criteria that allows us to do testing. Triple negative breast cancer at any age, male breast cancer. Family history, what we're really trying to focus on are those 1st and 2nd degree relatives. So that's myself, my siblings, my children, my parents, my aunts, my uncles. Cousins are 3rd degree. Not that we don't consider cousins, we definitely do, but it goes into the whole picture about the family history. One of the hardest things that I manage would be insurance. So insurance does not always align with the National Comprehensive Cancer Network guidelines that we follow. So sometimes we have to look at what that particular insurance company uses for their own guideline. And sometimes they are not as inclusive as the national guidelines are. If that happens, of course, we would always submit letters of medical necessity, complete whatever paperwork is necessary for insurance. But it may come down to that we need to talk about doing self-pay for testing. Fortunately, there are several laboratories that offer a competitive self-pay price. One in particular offers the 84 gene panel for $250. So that would be not using insurance at all. Leslie, do we have a question?
Yes, it just came from me. Am I still muted?
You are on now. Yes.
Okay, good.
Considered 2nd degree.
Grandparents are 2nd degree?
Grandparents are 2nd degree. So basically it's you're like you're skipping on a rock from one rock to another. I skip one time, that's 1st degree. I hop to the next person, that's 2nd degree, and on from there. Yep. So they're really important.
Are parents and aunts and uncles 1st degree?
Parents and children and siblings are all 1st degree. So they're in the closest bubble to you. Aunts and uncles would be 2nd degree.
So aunts and uncles and grandparents are both 2nd degree.
Yeah. Okay. So it's like the further you get out in the circle. Yep.
Thank
yeah.
you.
So all important. But if I had somebody say, I have a second cousin that had breast cancer at age 50, and then we've got 12 other people between them that have never had cancer. I'm not going to be too worried about that, but it just depends on the guidelines. Yep.
Perfect, thank you.
You just answered one of my questions. The only family member we know of that ever had breast cancer or really any kind of cancer was my father's first cousin. So that would fall way down.
Exactly. Yeah. First cousin once removed to you
Yeah.
is,
Yeah.
and the way that we think about that is if that relative did have a mutation, and then you were to go through tracking, what is the possibility that going through the family tree, person by person, that you also have it, it gets down to be so watered down that your risk would be about average. It would be about as if it wasn't there in the
Okay.
family.
Gotcha.
But of course, I don't want anybody to, discount any family history of cancer. If they have a concern, they should talk to us about what that risk might be. For sure.
I'll be asking you a question at the end where our family is not watered down at this point because of my sister and me, but I'm saving it until the end.
That
so
sounds great. Yeah, I love questions. Yeah,
I'll mute myself for now.
Yep. No, that works perfect. I love questions. All right, let's see here. Okay. All right, so let's say somebody did genetic testing and we get these results. What do they really mean? All right, so a negative result means that your testing is normal. Okay, and there's different scenarios on how we interpret a normal result. So let's say that the person, we know that a close relative of theirs has a genetic variation, like a BRCA mutation or PALB2 or whatever. Our goal first is always to test the relative in the family who has cancer. I see lots of people who want to have testing who have a family history, and that's great. We definitely do testing on people that don't have cancer, but if you ever give me the possibility to test the affected person, that's who I want to test first, because I want to establish one for one, the person, the relative that has cancer, this is what their genes look like. And if something's positive, I want to be able to offer that one gene specifically to my patient. Okay. So let's say we have that scenario. The family member has been tested, a mutation has been found in the family member, but I get tested for it and my result is normal. That's considered a true negative. Because I do not carry that one genetic variation that my sister has, then my risk for cancer is now equal to the general population. It's not zero, right? Because we can have families that some people have cancer for a hereditary reason and their brother or sister could have cancer because of an environmental reason. So you have to look at it individually. You always do your screening. But that is the most reassuring situation that we can have. Family member gets tested. We know they have a mutation, but I for sure do not have it. The second thing would be that we know that the family member has had cancer, but we don't know if they have ever had testing, or we just can't get a hold of those records. We don't know. So I go ahead and do testing and it's normal. Okay. That's great. My result is very reassuring for me. That tells me what my genes are. That tells me that I have no known mutations in any of these genes, and that's very reassuring. We still want the family member who's had cancer to consider doing testing, right? Because we want to make sure that there's not anything in their genes that we could be missing overall. One of the things, and I can't go into it because it's kind of detailed out to do it, but just know this, there is a way to be able to estimate a woman's lifetime risk for breast cancer based on her family history, her breast density, whether she has dense breast tissue, her pregnancy history, her weight, whether she takes hormone supplements, what else? Several things like that. So it's assessing our full family and hormonal history to tell biopsy results. That's the other thing. If somebody had a breast biopsy that didn't show cancer, but it showed some abnormal cells, we can incorporate that into this risk model. And if your risk in your lifetime of breast cancer is greater than 20%, then you could qualify to do a breast MRI every year as a screening. That's in addition to doing a mammogram. So sometimes what happens is I will see my first person in the family that's had breast cancer. We do genetic testing and the testing is normal. And we say, that's great. That's such great news. We don't have some type of a genetic variant in the family that we need to offer testing to. But then that woman, because of her family history, says, well, I still would like for you to talk to my daughters because we want to know what their risk for breast cancer is. And so I may do a separate appointment for a daughter or a sister to look at their overall risk for breast cancer. And then we can refer them to a surgeon for screening. So again, that's breast MRIs or even using some of those medications that block estrogen to reduce the risk for breast cancer. All right. The next thing would be if I have had cancer myself and I do genetic testing, then what does that mean? So this negative result, again, is very reassuring. It means we've checked my genes and we didn't see anything. There could always be a gene that hasn't been discovered yet. Could be a gene that is unique to your family. We never ignore history. We never discount the family history or personal history just because of genetic testing being normal. So we would still recommend, screening on a regular basis. All right, so what if this testing is positive? All right, so when we do genetic testing and we do one of these large panels, it's going to tell us every gene that was tested. And then for each result, is it normal or is it not normal? So when there is something positive or not normal, the first thing we're looking at is what is the gene? Does it actually relate to the breast cancer history that we have? Second, what does it mean for our treatment? So if the woman is currently undergoing treatment for breast cancer, then what we want to think about is, do we need to alter what we consider for surgical options? It's never a requirement to do a mastectomy just because a genetic test result comes back positive and indicates an increased risk to have more cancer, but it's an option. So that's one thing that we look at is whenever a gene is positive, are there recommendations for bilateral mastectomy? Prophylactic, meaning that there's not cancer in the breast, but removing the breast tissue to reduce the risk for breast cancer occurring in the future. Okay. So as far as current treatment, what surgical options does it alter? Are there any medications or treatments that we should offer based on that specific genetic result? The next thing would be future beyond treatment, current treatment plan. What kind of screening? Again, breast MRIs, mammograms at an early age. We really don't start mammograms until age 30, but we can do breast MRIs earlier than that. And there may be scenarios for mammogram earlier than 30, but still many of our recommendations would, if we have a very increased risk, then we would do breast MRIs first. And again, prophylactic mastectomy and oophorectomy or removing the ovaries may be indicated based on the genetic result. All right, the last thing would be whenever my genetic testing would come back positive, then that information is very important for my close family members. So we want to be able to provide information that the patient can give to their family members so that they can consider testing. I will not contact your brother or sister or cousin. I don't do that, but I will give you a copy of your result. I will give you a letter explaining the result, and then you can make a decision on who you want to inform in the family. Obviously, your children, your brothers and sisters, your parents would be the first line. They've got the highest risk, which is 50%. There's some things that we like to make sure that people think about before they do genetic testing. One would be the timing of that testing. We don't often do cancer risk testing before age 18 because many of these genes that we test for, they're not pediatric cancers. They're not things that are going to impact medical care in childhood. So we would wait until over age 18. Some people may want to consider whether they'd like to get life insurance before they do genetic testing. Life insurance can take into account any kind of, medical fact about yourself, and they do ask about family history often. And then the last thing is just the impact of a positive result. Are you ready for possibly hearing that you have a 80% lifetime risk to have breast cancer? Are you ready to consider all of these preventative surgeries? What would that do to you, your career, your self-image, all of those things? We like to think that genetic testing is empowering because it's giving you information that will help us make decisions and choices that will hopefully help catch cancer early or even prevent it, depending on what the cancer is overall. Now, I threw this in here because for people who have had genetic testing before, they may have been told that they had some type of a variant of uncertain significance. These things are not my favorite friend, but overall, we want to keep in mind that not every change in every gene is actually a problem. So our genes are, again, like recipes, and you can have a subtle change in that sequence of that gene and it not damage the gene's function at all. So some changes in genes are just normal variations from one person to another. So different places in the world, different families can have subtly different variations on genes. What we're concerned about for a gene result to be positive is that genetic change affecting the gene's function? Does that gene actually do its job properly, even with that spot? And I also like to think about these results as being like a research result. It helps us learn about our genes, and the laboratories have a system in place that they study on certain results, and then they contact me and I reach out to the families if a result gets reclassified to actually be significant or important. Thankfully, most of these results, they get downgraded to normal variations in time overall. All right, so just a couple other, and I'm happy to answer some more specific questions about these things, but I wanted to at least give you a little information about Levine Cancer Institute specifically. So we offer phone genetic counseling and in-person consultation. Now, a lot of people ask me about the cost more than 10 locations, and that is a complicated question. There are two parts to this. One is the cost of testing depends on whether you meet these national criteria and or insurance criteria set by your insurance company. That's part one. That's the is it really necessary piece. Part two is if the testing is really necessary, what does your particular plan say about it? Do you have a deductible? Do you have co-insurance? So we will work with the insurance and the laboratory to try to get a benefits investigation done to tell us what the estimated out-of-pocket cost is. Most of the labs that we work with use a self-pay price if insurance is either declines the testing, says it's not indicated, or if they say that your deductible is higher than the self-pay price, then the labs will often offer you the self-pay price. So again, that's very individual. The labs like to say that about 90% of people who have met their deductible pay $100 or less, but it very much depends on the particular plan and someone's deductible on how much they might pay out of pocket. During our appointments, we may also make referrals to other providers. I mentioned about the breast surgeons to discuss high-risk screening and breast MRIs, but there could be anybody else in the system. Levine Cancer Institute has dietitians and social workers and all kinds of other health professionals that may be beneficial for somebody's cancer treatment or long-term care. And so we're happy to help get someone connected into that system. My email is there on the slide, and also the main phone number for Levine Cancer Institute if somebody has a question. And that is the end of my slide. So I would be happy to take any questions that you have.